All right, everyone, according to my clock, it's high noon here, so we're going to get started today. So I wanted to welcome everyone. Thank you very much for taking the time to join us for today's session on responding to anti-Indigenous racism in the healthcare system. We're really thrilled that you could take the time to join us, and we certainly really appreciate our speakers and our elder joining us today. Before we get started, we wanted to just give you a quick orientation to the background and software that we use for these webinars. In terms of interacting with webinar or WebEx, which is the platform that we use on these calls, just have a bit of an overview in terms of some of the things you can do. And really what I wanted to bring to your attention was on the bottom right-hand side, and that's the chat box. We really do invite you to take a couple minutes to introduce yourselves in the chat box and where you're from. When you're using the chat box, I want to encourage you to make sure you select all participants when you send a message. That will enable you to send a message to everyone on the call, and we can all see who you are and where you're joining from. We're not going to be using a lot of the other functionality today, but one of the things I did want to bring to your attention was the hand option. So you'll notice in the middle of the right-hand side of the screen, there is an icon for a hand. If you click on that, a hand will show up beside your name. If you click on it again, it will disappear. So if you have any questions, because we have muted all the lines when it comes to question time, we invite you to raise your hand and or pop your question in the chat box. Moving right along, we also wanted to make sure that you're connected. You have the ability to mute and unmute lines, but in this case, we have muted all the lines on today's call. But one thing we do find is that sometimes the quality of the sound is a little bit better when you use a phone versus a computer. If for some reason there is no phone icon beside your name, what you can do is to stay on the WebEx, so the computer piece of things, hang up your telephone, and a pop-up window will appear. And you could always, if it doesn't appear, you can click on the audio button. And we invite you to use the dial-in details to have the WebEx either call you or for you to call in for the call. I already highlighted this, but just a reminder about the WebEx chat. We really do encourage you to introduce yourselves, and on the bottom right-hand side of the screen, let us know who you are and where you're joining us from, and just ensure you select the All Participants option. And then again, we invite you to pop your questions in that box. I want to remind everyone that we are recording today's session. We record these sessions so that we can make sure they're available for use. All the materials, the recordings, and the slides, a slightly modified version of today's slides, will be distributed by email to all participants and posted on both the Council and the First Nations Health Authority website. So we want to rest assured that you'll be able to access these slides as well as the recording from today's session and be able to share them. For those of you who are on social media and want to roll up your sleeves to do some tweeting during today's call, Sue has kindly popped all the hashtags and Twitter handles in the chat box. I also have them up on the screen right now, and really invite everyone, if you are on Twitter, to let's spread the message even further. We've had incredible learning and reach with these sessions, and we'd like to keep seeing that grow. I wanted to remind everyone and really invite everyone to ensure you are taking care of yourself during these calls. These sessions often cover sensitive subject matters and stories that may trigger people. So please ensure you have a support system in place. This may be an elder, trusted mentor, family, counselor, etc. We really know that this session in particular is going to share some examples that may be difficult. If you need support, we have shared the 1-800 crisis number on the line here. And Sue, if you'd be so kind to also pop that in the chat box, that would be wonderful. So that's the 1-800-588-8717. So it's with pleasure now that I get to introduce our elder. Virginia Peters has joined us on this entire journey with these webinars and has really been our anchor at the start and the closing of each event. And we're truly honored that you're able to join us again today, Virginia. Virginia Peters is an elder for the First Nations Health Directors Association and has worked in First Nations Health programming since 1972, which is an incredible history in terms of your contribution to the system. She was born, she was a manager of health for Staley's for many years. Virginia Peters was born to William and Nancy Phillips from Chehalis, BC. Her immediate family consists of 3 daughters, 2 sons, 10 grandchildren, 6 foster grandchildren, and 19 great-grandchildren. She has a very large extended family and definitely over 1,500 people. The family is very close-knit and is strongly linked with the extended family. Being a family and community-oriented person, Jenny continues to dedicate much of her time and effort to assist with community development healing, and her contributions to these sessions are just remarkable in terms of the knowledge that you ground us in, Virginia. Virginia firmly believes that culture and spirituality is the key to healing and rebuilding the strength of our families and communities. I'd like to invite you now to start our session together today, Virginia. Thank you again.
ACM. It's wonderful to be together. It's a wonderful day, and it's so wonderful that so many of us can be gathered, with our minds, our spirits, to be able to talk about things that are so sensitive to us. And so it is always good to have a prayer to ground us and to help us through the discussions that are going to be following. So I have a prayer song that I'm going to be singing. Oh, oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Hand of God, touch my heart. Hand of God, heal my heart. Hand of God, take my heart home and forever be with you. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Hand of God, touch my soul. Hand of God, heal my soul. Hand of God, take my soul and forever be with you. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey. Oh, hello. Oh, hey.
Thank you very much, Virginia. We so appreciate you honoring us with joining us today and grounding our session in your opening. I wanted to take the opportunity as well to thank the First Nations Health Directors who have supported you joining us today as well, Virginia. We really appreciate it. As we move on today, It's with pleasure that I get to introduce Yvette Ringham Cowan and Laurie Harding. Yvette and Laurie are both from Provincial Health Services Authority, and they're going to be doing a presentation today on responding to anti-Indigenous racism in the healthcare system. Yvette is of mixed Kwakwaka'wakw and English ancestry and has been working as a cultural safety facilitator for several years, focused on supporting non-Indigenous folks to increase their own and their organization capacity to create cultural safety interactions or culturally safe interactions and environments. She has joined the SANIAS team from Vancouver Island Health, and Yvette's holds the position of ICS Integration Lead. Working really on the development and implementation of ICS knowledge integration activities and the ICS strategy. Laurie is a white settler and Scottish and English ancestry and has been working as a cultural safety facilitator with the SANIAS team for 7 years. She supports non-Indigenous settlers and organizations to increase their capacity to create safer care interactions. Her doctoral research is focused on the impact of Indigenous stereotypes on service providers' attitudes and actions. And Laurie is currently an Indigenous Cultural Safety Integration Lead, which involves working to help providers integrate cultural safety knowledge into their work or practice. I also want to acknowledge Cheryl Ward, who was unable to join us today. She is in our thoughts and prayers, and really delighted to thank you, Yvette and Laurie, for joining us, and handing it over to you now. Thank you.
Thanks so much, Colleen, and thank you to everyone, and good morning. I'm very honored to be here speaking to you today. I realize this webinar is for all of you in BC, but right now I'm coming to you live from Thunder Bay. So I'd like to acknowledge that I'm in Robins Superior Treaty Territory, the traditional territory of the Anishinaabe. Usually you can find me in unceded Lekwungen territory, also known as Victoria, which is where I live. My name is Laurie Harding. I'm a white settler with Scottish and English ancestry, and I purposely identify my colonial roots because they cannot be separated from my experience living in Canada on Indigenous land. As Colleen mentioned, I'm currently an integration lead with the SANIAS Indigenous Cultural Safety Training Program, and prior to that role, I was a facilitator with the program. So some of you might recognize my name if you've taken the training. I'd also like to acknowledge our leader, Cheryl Ward, who wasn't able to present today. Cheryl is Namgis, and she's the Interim Director of PHSA, Indigenous Health, and the developer of the SANIAS curriculum. The material in this training is largely based on her work, and so we would not be here today if it were not for her vision and leadership. I'll turn it over to Yvette to add some about her own introduction. Thanks very much.
Thanks, Laurie. I'm also honored to be speaking with all of you today. As mentioned, my name is Yvette Ringham Cowan. I'm of mixed ancestry, so I'm Kwakwaka'wakw on my mother's side and third-generation English settler on my father's side. And I, too, live on unceded territory of the Lekwungen-speaking peoples in Metulia, aka Victoria. And I'm speaking to you today from our program office, which is located on Musqueam, Squamish, and Tsleil-Waututh territory in Vancouver. I'm also an integration lead with SANIAS, and Laurie and I work closely together. So there's a Kwakwaka'wakw saying that all meetings are transformational. So what brings you here today? What brings me here today is my lifelong and deep commitment to correcting the inequities that I, my family, and other Indigenous peoples have historically experienced and continue to experience today, particularly in healthcare. Laurie, what brings you here today?
Thank you, Beth. What brings me here is my recognition that I'm a white settler, and I realize that this colonial system has been designed to benefit me, my family, and other non-Indigenous settlers. I'm here to support other settlers like me and my family in recognizing the systemic advantages we have and moving this conversation along. We invite all of you to think about why you're here. I'll turn it over to Yvette to review our intentions for today.
Great, thanks, Laurie. So our intentions in speaking with you here today is to draw on our experience with the SANIAS Indigenous Cultural Safety Program to discuss the harms that Indigenous people often face in the healthcare system. We'll begin by setting the context for Indigenous Cultural Safety training, and then we'll explore the common stereotypes of Indigenous people. We'll discuss how stereotypes can lead to harmful behaviors and provide examples of where harms to Indigenous people tend to occur within the health system. We'll then talk a bit about Indigenous cultural safety and what it means, and provide examples of what you can do at an individual and organizational level to address these harms. We'll conclude with some calls to action for responding to racism in your workplace or other healthcare settings. So an agenda for change. It's important to begin with some context for the development of SANYAS. Cultural safety is not a new concept, but over the last couple of decades, we've seen a changing landscape that has enabled opportunities for pushing a cultural safety agenda forward. The 2005 Transformative Accord, including a mandate to develop Indigenous cultural safety training in BC. This was the impetus for SANYAS. Since that time, we've seen cultural safety recognized in the Truth and Reconciliation's calls to actions and the signing of the Declaration of Commitment on Cultural Safety and Humility in 2016, demonstrating that cultural safety is an explicit priority in BC. The SANYAS program sits within the Provincial Health Service Authority in Indigenous Health. Cheryl Ward developed the foundational curriculum to address issues of bias, stereotyping, and discrimination in the health system. So our mandate with SANYAS was to provide this core foundational training to all healthcare workers in BC. The training was launched in 2010, and since then we've trained upwards of 40,000 people in British Columbia, Ontario, and Manitoba. The program is grounded in a critical anti-racism and transformative learning pedagogy, excuse me, which means the curriculum is designed to enable, just going to take a drink here. So it's designed to enable people to recognize and counter racism and to shift their own views and assumptions about Indigenous people. The goal of SANYAS, which means knowing, or to know in the Kwakwaka'wakw language, are to increase awareness in colonization and the impacts on Indigenous people, enhance knowledge of the concepts such as racism and social determinants of Indigenous people's health, and develop skills to work more effectively and safely with Indigenous people. So the program is unique in that it is online and facilitated. A lot of thought has gone into designing the platform, which was customized specifically for this purpose. We've tried to make it as interesting and engaging as possible, with plenty of interactive activities, including quizzes, drag and drop activities, personal journal entries, and group discussion boards. There are between 20 and 30 videos in the curriculum because we believe that people are the best teachers, and that's how we do that in a virtual classroom. Learners go through the training in cohorts of 25 people, and each cohort has its own facilitator. The facilitators are skilled in meeting people where they're at and pushing each learner to go a little deeper into the material. Facilitators respond to learners' journal entries, and they also have a presence on group discussion boards. This style of learning is effective for tackling tough issues like stereotyping, prejudice, discrimination, and bias. So now I'm going to turn it over to Laurie to talk about what we've learned from delivering this training.
Thanks, Yvette. As Yvette mentioned, during the training, participants are asked to reflect on the group discussion boards. And one of these discussion boards is focused on stereotyping and discrimination. We were surprised by the stories and examples of harmful care that started to surface en masse through this discussion board. And we found that these stories give us insight into where and how harms occur in the healthcare system. These insights can further inform our thinking on what we can do to address these harms. We have permission to share these examples for the purpose of learning, and we'll be sharing some of them with you today. These examples are used to help us understand how Indigenous people experience care, and some of the experiences are intense and can be personally impactful. This can be especially true for Indigenous people who may be listening. It's important to note that when hearing these stories, we can sometimes be affected in unexpected ways, and this is normal. It's important to take care of ourselves and of each other. This is one story a participant shared to illustrate the harms that can occur to Indigenous people when getting care, even when unconscious. And I'll read the quote. I can think of several examples of incidents of racism and stereotyping that I've witnessed working in healthcare. The one that always springs to mind first was working in the OR when an Indigenous woman was having joint surgery. The surgeon was being brutal in his handling of the patient, but would no doubt result in increased pain and a longer recovery time for the patient. The comment he made was, I don't know why I have to do this surgery. She won't get her lazy ass off the couch anyhow. I happen to know that the patient was an active member of the police force. I remember being horrified but frightened to identify this treatment of the patient as abusive for fear he would continue his tirade and the patient would suffer more. It was a helpless feeling. Difficult to read and hear, but let's unpack this example. Let's take a look at how we got to this place. So how did we get here? To answer this question, we can start by thinking about what it means to be in Canada. On one hand, on the left, we see an image of Canada as a model of liberal ideals of democracy, equality, tolerance, multiculturalism, harmony, accommodation, and so on. Juxtaposed to this is the reality of Canada experienced by Indigenous people and other racialized Canadians, which has been shaped by racist ideology, paternalism, cultural genocide, violence, and racism. The issue is not that one perspective is right and one is incorrect. Rather, the issue is that each reflects a standpoint that is differently shaped by race and the colonial context. We often refer to these issues around race and colonial context as the elephant in the room. That's a nice big one, eh? Isn't he gorgeous? So, everyone knows you there. Everyone has some idea about these issues, but no one talks about it or acknowledges it. In an Indigenous context, the elephant holds the belief about vacant land, forced relocation, the theft of land and resources, the erasure of colonial history and privileging of settlers, and the violence of racism. These issues are key to examine in order to understand anti-Indigenous racism, and we go there in the ICS Indigenous Cultural Safety training. Here we have an image about pedagogy. We focus on racism due to our critical anti-racist approach. We've created a unique online facilitation training model, and our work is critical. Our philosophy has emerged in correlation to our experience with the program. At a very foundational level, we're addressing tremendous gaps in knowledge and self-awareness. We continually research best practices about prejudice reduction strategies and how to address racism and discrimination. This is an area that is difficult to teach and difficult to learn, but fundamental to the work we do. On one level, we aspire to help people understand the nuances of cultural difference, but the reality is that most people are not there yet. First, we need to address critical issues of misinformation about history and the legacy of settler privilege and authentic ignorance. We center Indigenous perspectives and experiences in this training, and this helps us to keep focused. This training applies a decolonizing lens, and it is anti-racist. It addresses both individual and structural racism. Investigating. After 7 years of delivering Indigenous cultural safety training, we've learned a lot about how anti-Indigenous racism shows up in healthcare settings. The stereotyping discussion boards in the ICS training program provide a particularly rich data set to begin examining the issues around stereotyping more closely. We had permission to use the data for research purposes, and I requested permission to analyze this data for my doctoral research. All the comments posted on the stereotyping discussion board during the year of 2014 were gathered. This yielded over 3,800 comments about the ways Indigenous people are stereotyped. A random sample of 25% of the comments were analyzed, and through this process, 44 different stereotypes about Indigenous people were identified. This word cloud, or wordle, illustrates the most common stereotypes that were identified in the data. The size of the word is related to how often the stereotype appeared in the data set. For example, the bigger the word, the more often that stereotype was identified. These findings support what we've found in the literature around the prevalence of these stereotypes. As you can see, the stereotype around alcohol is by far the most prevalent. These are the top 10 stereotypes that I saw in the data. Some of these may be familiar to you. The stereotype that Indigenous people are, in quotes, drunk or alcoholic is the most common, and these have a potential for a great amount of harm. The stereotype that Indigenous people are all, quote, addicted or drug-seeking, unquote, is also very common. You can see the other stereotypes here, and I'll list them. That Indigenous people all get or want free stuff, that they are promiscuous, not smart, or are illiterate, they abuse the system, don't cooperate with healthcare providers, or are non-compliant, are lazy, can't get over the past, and are bad or neglectful parents, end quote. Let's take a breath. I acknowledge this can be hard to hear and even harder to experience. These stereotypes have been very harmful and have effects on Indigenous people across the healthcare system. They can be life-altering and have even lethal consequences. I'm now going to share some examples from the data to illustrate these stereotyping harms. The first one, on alcohol, this quote illustrates that the stereotype around alcohol, what it looks like and it sounds like, and this one is particularly significant because it's about a child. And I quote, an impactful example of stereotyping occurred when an Aboriginal youth, 10 years old, was seeing a local Caucasian specialist who asked the child what his favorite color was. The child answered red. But then the specialist responded, no, it's blue. Labatt's blue? Get it? There's no question that the stereotype of alcohol use is overwhelming, everyday, and commonplace. And the relationship between this stereotype and harm is strong, and there is evidence that it influences all forms of healthcare, including behaviors that contribute to death or the worsening of health conditions. The next one, drug addicted or drug seeking. This is another very common stereotype that's potentially extremely harmful, the stereotype around addiction. This example is offensive. However, we've seen the stereotype cause harm and very serious injury, and as mentioned, it plays out in all kinds of ways throughout the health system. I'll read the quote. One particular story that bothers me to this day is when I was working on the floor with a nurse who happened to have caught a glimpse of an Aboriginal woman walking down the hallway and distinctly said to me, go tell her we don't give out drugs here. This particular lady was my mother, a fellow nurse who came to visit me. The next one is promiscuous. This is an example of stereotype that Indigenous people are promiscuous, which has a particularly harmful impact on Indigenous women. And the quote says, I had a senior obstetrics resident tell me the best thing for Canada would be if Native people stopped reproducing. When we read this example, we can imagine how this would impact the care of an Indigenous person. What effect do you think this attitude might have on how this resident treats Indigenous people? I invite everyone to think about how this attitude might shape the resident's behavior and how this in turn might affect the Indigenous person's care and their health. Okay, so how do we understand that? We've read thousands of examples that we've mentioned already, and they show the connections between beliefs, attitudes, and behaviors. This framework can help us deepen our understanding of how implicit bias and stereotypes can lead to harm. We refer to this as the pathway to harm, and Cheryl Ward adapted this framework from Jackson's work in the psychology of prejudice. This lens can help us to deconstruct stereotyping and discrimination and help us think about how to interrupt the path from thought to action. You can see that there is a trajectory here across from left to right, stemming from colonial ideologies or worldview, which leads to stereotypes or beliefs about Indigenous people, which leads to prejudice or certain attitudes towards Indigenous people, which potentially in turn leads to discrimination, which is when behaviors cause harm or result in Indigenous people being treated differently or poorly. We know that stereotypes do not always have to translate into behavior, but what is needed are the skills to identify them in order to intervene. The harm can be stopped before the stereotype results in damaging attitudes and actions. In the Indigenous Cultural Safety training, we assist participants to become more conscious and actually interrupt these dynamics, either within themselves or in others. So, what are those harmful behaviors? Recognizing harmful behaviors that stem from stereotyping is a key step to interrupting this pattern and working towards more culturally safe practice. The analysis of the ICS data revealed several harmful behaviors that healthcare professionals exhibit on the basis of stereotyping. These are the most common behaviors related to the care for Indigenous people in the order of prevalence, and I'll provide examples for each. The first is less effort. The data revealed that stereotyping can contribute to providers spending less time and effort on Indigenous patients. A young mother brought her small child into the emergency department. Their prejudice was clear in their quick dismissal for her 2-year-old little girl. This little girl lost her battle with a raging infection, which, if treated in time, could have been stopped. This is a tragic example. We can see the extent of harm here due to prejudice and discriminatory practice. The next is misdiagnosis. It's also very common for Indigenous people to be misdiagnosed based on stereotypes around alcohol. Here's one example. I came into the ER one afternoon to take over, and I noticed that a First Nations patient had been restrained all night, morning and afternoon, with no safety checks. He was restrained because he had punched an RN because he was drunk. Further testing revealed that the patient had a stroke and 0 alcohol level. The next, delay, denial of service. Even though emergency departments are places where you're supposed to go for urgent care, Indigenous people are frequently dismissed, turned away, or denied care altogether. For this example, a young Aboriginal couple came to Emerge over a weekend, worried about their newborn baby, and were sent away twice. When they came back, yet again, the baby was gravely ill and suffered permanent and eventual fatal consequences to an initially treatable condition. This is yet another example that could have been prevented. Please keep in mind I'm sharing these stories because situations like this often go unreported, even though it happens on a regular basis to Indigenous people. Our hope is that by bringing these examples to the surface, we can draw attention to them and then take action towards preventing these unjust harms. And what conditions are minimized? Here's another example of how providers often minimize the severity of Indigenous people's health conditions. An Aboriginal client, an elderly woman, had come to see me. She had a physician she was seeing for years, and for more than 2 years, he prescribed antacids for her stomach pain. She went back to her physician, as she regularly did, to complain of her stomach pains, but this time he was away on vacation, and she instead got to see a new physician. This turn of events was a blessing. She was immediately sent for testing and subsequently diagnosed with 2 stomach cancers. No medication or pain medication. I'll read this quote. I'm an oncologist. I have many Aboriginal cancer patients who have palliative cancer diagnosis. On multiple occasions, I have had trainees or GPs working with me refuse to prescribe Aboriginal patients with opioid analgesics, for example, morphine, after writing comments in the chart regarding fear of substance abuse despite obvious benefits they could receive. I find it awkward trying to discuss potential stereotypes that trainees have, and even more awkward trying to convince the patient's own family physician that they should provide palliative pain medication for a dying patient. This is not an uncommon situation, and there are many examples where Indigenous people have not been provided needed pain medication because of misinformation and stereotypes about alcoholism and drug-seeking behavior. And lastly, we're going to talk about the hotspots. Through the analysis of data, I was able to identify the areas of health system stereotyping where harms tend to occur. We refer to sites where harms are particularly rampant as hotspots. This is a list of the hotspots in the healthcare system. And this list is also consistent with the literature and other research studies that examine Indigenous people's harmful experiences of healthcare. Understanding what harmful behavior looks like and where harm tends to occur can give us insight into what we can do about it. I'll pass the mic over to Yvette to shed some light onto what we can do.
All right, well, I really appreciate you sharing all of that with us, Laurie, and I just want to once again acknowledge how difficult listening to this information is, and the importance of moving this conversation forward in a really meaningful and assertive kind of manner. So, what can we do? You know, there are a spectrum of approaches that we can take to begin addressing these harms. Stereotypes is one such example, and it's rooted in the concept of cultural safety. So for us, there's three important pillars of cultural safety. It's an ongoing process of actively working to make systems safer and more equitable for Indigenous people. So the goal of cultural safety is to continually assess the quality of care, adapt services to better meet Indigenous people's needs, and ultimately improve the quality of and access to services. Cultural safety is focused on the colonial context. This is accomplished by paying attention to the historical, socioeconomic, political influences on Indigenous people, and by addressing the structural inequities. Cultural safety is also an outcome. It is tied to improving the experience Indigenous people have within the system. It's achieved when Indigenous people receive equitable care and timely access to services, and feel both safe as clients and as employees in the system. So a spectrum of approaches. We recognize that cultural safety exists along a continuum. At one end of the continuum, we have cultural awareness and sensitivity, which are about focusing on culture and cultural difference. This includes focusing on diversity and multiculturalism, which can be a starting place for some organizations. Focusing on this end of the continuum presents risks for reinforcing stereotypes and framing Indigenous people as the other. We know this approach does not address the root causes of harm Indigenous people often experience in the system. So in the middle, we have cultural competency and cultural humility. These are about practitioners changing themselves. This is needed to make a difference in the quality of care Indigenous people receive. It is the what and the how in relation to our own skills working with Indigenous people. So cultural safety is our goal. It is about when Indigenous people feel safe within the system and are not discriminated against or stereotyped. Indigenous people must be the ones to determine when the system is safe. So in order to get there, we need to think about what kinds of individual and organizational interventions will lead to this transformation. Stereotypes is one intervention that can work towards interrupting harms in that it supports learners to identify and interrupt stereotyping and racism in the workplace. Because it's rooted in cultural safety, it is focused on individual and organizational behavioral change and not on teaching about culture. This is a key feature that makes Stereotypes unique from other types of cultural awareness or diversity training. The focus on culture is very prevalent in some contexts, and Indigenous scholars such as Emma LaRocque have been writing about this issue for some time. LaRocque writes, colonial policies have had devastating impacts on Native peoples, but the fallout has been explained away as stemming from cultural differences. She then goes on to say that in turn, cultural differences are reduced to stereotypes and Indigenous culture rather than colonization and racism, and is blamed for whatever has happened to Native peoples. Essentially, what is meant by this is that stereotypes of Indigenous people are believed to be rooted in Indigenous culture rather than being rooted in colonization and racism. So we know culture has a very important role to play. One of the challenges is figuring out where culture fits in to the trajectory of learning. So we take a scaffold approach to the learning so that learners are taught about culture and protocols, for example. They will have a foundation of core skills to build upon. SANIAS is intended to be the core training that forms this foundation. After taking the core training, in-person debriefs and advanced trainings are needed to support learners to embed Indigenous cultural safety into practice. We call this integration. After integration of the core skills, learners will then be better equipped to apply locally tailored and nation-specific training. So our goal here is to continue building on the foundation of SANIAS to continue this trajectory of learning. So how do we know that this approach works? What are the impacts of SANIAS? We've taken strides to assess the impact of SANIAS as a behavioral intervention. One of the ways we've done this is through the development of a post-activity reflective exercise, which is completed 3 to 6 months after the core health training. Currently, this exercise is only completed by physicians who receive continuing education credits for completion. The exercise asks the practitioners how the training has impacted, informed, or shifted their practice. So here we have a couple of examples from the post-training activity to illustrate how the training is having an impact on practice. So I'll read the quote. Oftentimes, before I completed the training and had encounters with Indigenous patients, I would be frustrated with the sometimes long narratives that I did not feel were clinically relevant. I am now more mindful that these narratives are important and less inclined to interject to try to speed things up. And the second quote, I respond differently to negative comments made during team discussions about patients. Several nurses I work with make negative, generalizing comments about Indigenous people. When that occurs now, I try to gently point out the negative stereotypes and see how we can reframe the issue they are facing. So these excerpts suggest that training is having an influence on shifting providers' practices by challenging their own assumptions and actively interrupting stereotyping. So it's important to note that we recognize training alone will not sustain behavioral change, and that structural interventions are needed in order to support changes in practice. So another key challenge in trying to address harms is that it's often assumed that racism is caused by racist individuals. We try to continuously emphasize that racism happens on a structural level. So this means that our policies, processes, and workplace culture are what allows stereotyping, prejudice, and racist behavior to continue. We find that when people hear these stories about Indigenous people experiencing harmful care, like the examples that Laurie just read, there is a tendency to want to point the finger at someone, but we know that just firing people will not make a difference to improving the quality of care. Addressing inequities is not just about identifying racist individuals and removing the bad apples in our systems. It is about changing the organization and the workplace culture at the structural level. So one strategy for addressing racism at the structural level is to focus on responding to incidents related to racism. Laurie's data shows that there is a common complacency when it comes to anti-Indigenous racism because it is so normalized and accepted in our workplaces. We can see this in language that accompanies participants' descriptions of witnessing stereotypes and discrimination. As Laurie mentioned, we have thousands of examples of racism in healthcare, but this is not reflected in the number of documented incidents related to racism. We know that incidents are underreported and complaints are rarely made, which shows that our system for capturing data on racism are not adequate. Documenting, analyzing, and responding to racism-related incidents are key things we could do at the organizational level to start addressing harmful behaviors. So there's a lot going on in this slide. The purpose here, though, is to give you a snapshot of the range of interventions that could be implemented in an organization to respond to the multiple forms of racism. Anti-Indigenous racism, as you can see, takes on many forms, and interventions are needed at each of these levels. So a strategy we're working on at PHSA is an organizational framework for fostering Indigenous cultural safety. The framework has 6 domains, which you can see here, and SANIUS is one small part of this framework. It would be nested under the human resources, training, and staff development domain. I won't go into detail here. The point is to illustrate that comprehensive organizational frameworks and strategies are needed if we are to work towards culturally safe and less harmful health systems for Indigenous people. So calls to action. We'd like to leave you with some calls to action for addressing harmful practices in healthcare. So speak up. Talk about racism in your workplace with your colleagues, your friends, and your families. This is a message especially for non-Indigenous people, because speaking out against racism does not carry the same risk for settlers as it does for Indigenous people. Naming stereotyping. This is an essential first step towards interrupting harmful behaviors. Gather data on harms. This may first require collecting data on race, which is often not done. Examine why and where harms occur in your workplace. Analyze data to unpack what is happening. Reflect on how you could improve your practice or what behaviors need to change. And then reflect on what needs to change in your workplace or organization for Indigenous people to experience more equitable care. So I'm going to conclude here with a reminder from Elder Jerry Oldman, who invites us always to reflect on our own blind spots as individuals and as an organization. We can't say goodbye to a problem until we first said hello. In healthcare, we are so often encouraged to focus on our feats and our successes. Yet if we don't know where our shortcomings are, we won't know how to fix them. We encourage all of you to continue working towards cultural safety by reflecting on your own practice, your workplace culture, and to think about what changes are needed to make our healthcare system safer for Indigenous people. Thank you.
Thank you so much, Laurie and Yvette, for sharing this. And I think some very compelling stories that you've shared in terms of really the need to examine where and why harm occurs as a starting point for learning and action. And I love your call to action in terms of, how we look at our own practice, workplace culture, those structural elements that really influence what happens in our system. And I think you've shared some important material and food for thought in terms of how do we start moving towards action now. So thank you so much for sharing these stories and joining us today. I want to hand it over right now to Virginia to invite you to share your comments and insights before we transition into questions for Laurie and Yvette.
Good morning. Just listening to the presentations, that Yvette and presented. It's, brought a lot to my heart and to my mind. It is a difficult topic to talk about. So many of us have gone through, the racism and the prejudice. Our elders, had a way, our own ways of dealing, with things that were going on, within our families. But when they were brought to residential schools, you know, and deprogrammed, you know, taking the Indian out of them, they came out of there not really wanting to share our own ways. And so we have a lot of generations now, you know, and I think of my own family, you know, and I have 3 generations following me, you know, and my mom went to residential school. I went to residential school for a couple of years, you know, and we know, you know, the impacts that kind of life put onto us. And so a lot of the impacts still live on generation after generation. And we still are criticized, you know, for who we are. And we really need to do something about making some changes to how we treat our people, especially in our own community. So that Sania's training, you know, I think could really help us to reach the others, you know, that are providing services to our people. And we always say they will never fully understand because they've never lived it. We've lived it. They'll never fully understand, but if they can accept and respect and appreciate how this all came about, you know, it wasn't our fault. It was decisions that were made by people who really didn't understand, you know, that we're human, that we are part of the human race. And they wanted to change us from that. You know, we were the first peoples. So there's a lot of ways that we can incorporate some of our traditions, our customs, our beliefs into programs that we're delivering, you know, in our communities. And that's really, really important. And we need to be working side by side, you know, with the ones we hire to come work in our communities. The nurses, the doctors, the psychiatrists, the psychologists, you know, they all have a hand, and we all have our own gift of reaching out and providing the type of service, you know, that's really going to help our people. And most of it relies on who they are. They need to really get back to who they are and what their gifts are, because we all have something to give in this world. We were all given a gift by the Creator to share with others, not only family, but community, and even out further. And so it's the culture and the spirituality are really important to have within all of the programs and services that we deliver in our communities. You know, and now I'm starting to work with the inmates in the prisons, and the mental health services really need to be on the forefront, not only for them, but for many of our people still in the communities. Our elders have been really, really quiet for a long time. They didn't want to pass things on to us because they were, you know, they were told to be quiet, not to practice our ways. And our mom brought us up in that way. She said, they know best, so you just follow the authorities. But then in the late 60s and 70s and beginning of the 70s, we started working on reviving the traditions and customs and beliefs in our community. And we worked side by side with those that come provide services. We worked side by side with the church. We worked side by side with all the organizations that provide services to us. And I think that's a way to go. We need to blend all of that in order for us to provide a better service so our people can be proud of who they are and really take back their dignity and carry on in life in a better way. I know there's a lot I could share, but it would take too long.
We really appreciate you sharing that. And I think, sorry, I think you were going to say one more thing. I didn't mean to interrupt you. Please go ahead.
Yeah, because I've gone through all of that. We lived it. And for people, you know, for the training to take place and for people to gain a better understanding, we always say, you know, come and see us. It's better than trying to learn in a college or a university setting. If you come to our longhouses, or, you know, you got to see us, you got to hear us, and feel us, because it's different coming into First Nations community, and some people get turned off before they even, you know, take a position within our communities.
Thank you so much for that, Virginia. I think this session today is, I think, really helped amplify how the extent of how stereotypes in the healthcare system really do cause real and lasting harm, and sort of that history of a colonialism, that lasting impact. And I think, you know, hearing some of your messages, Virginia, even around grounding the work in culture and spirituality and pride and taking back that dignity, some of the things I heard you say. So thank you so much for sharing that. I've invited people on the call to join us to share their questions. There's a few that have come in, so I'm going to go to them now, if that's all right. The first one is from Kelly Wilson, and Kelly asks, Stanius trains 25 people per class. How many courses are offered each year? And the second part to that question is there any incentive for healthcare practitioners in the high-risk areas to take this course? So how many courses are offered each year, and are there incentives for healthcare practitioners in the high-risk areas to take this course?
Thanks, Colleen. It's Laurie here. I think I can respond to that. And thanks, Kelly, for asking the question, and most of all to Virginia for setting the piece there for us to all consider that we will never know, settlers will never know, fully understand that lived experience, and that's why settlers have to trouble these in depth so that we can learn what it is we're trying to address. Feeling sad is one thing, but doing something is where we want to go to. So I just wanted to thank you so much for your words there and that reminder. So regarding the intake for courses, as you mentioned, there's 25 each week, each Monday, and there are right now I think we've got about 13 facilitators. We're growing exponentially. So there, we take in, 25 times 13, and each person has usually about 6 to 8 cohorts. So we take in a lot of people, and the way the program is offered is that you have an 8 to 10 or 8-week window to complete it, and it's about 8 to 10 hours. So people are at various stages, and that's the beauty of online. You can fit it in. There's no requirement to show up at one time or one day. It's 24/7 open. So facilitators work, Monday to Friday to respond to each of the facilitation points throughout the training. And the question about identifying sites, that's up to health authorities. They decide, they register, they allow those seats. So when you go to the website, www.sonias.ca, there's more information there on how to register and how to go about that. And people in health authorities are supported to do that through their workplaces. There's also training across Canada. I see there were some questions about where else it's offered. So the program has been transitioned with curriculum for Ontario and Manitoba. And we've had people as far away as New Zealand take the course. So it is available for a fee online. And so the answer to your question, there is intake every Monday. And of course, there's the management around that, and that's taken care of by the registration team, and I couldn't speak to all of that. I hope I've answered that question. Does that sound like a response?
Absolutely. Thank you so much for that. Really appreciate it, Laurie. So one question that came in was a thank you again for the incredible presentation, sharing your learning from Stanius around cultural safety and humility and actions for moving forward. This question comes from a student and was wondering if the Stanius training is available to nursing students.
Some students are taking it. I think they'd have to talk to their faculty, and I think once they have a health authority email address, they can inquire. That wouldn't be, we don't decide who gets to do that. It goes through organizations on a higher level. So so she could, or he could check with the director of their program in nursing to find out about that.
Thank you so much, Laurie. There's a lot of questions coming in. One of them came into me privately, so I'm not going to announce where it came from, but it was inquiring about an opportunity for practitioners to be identified as allies once they have completed the program. So could there be an opportunity for something that where people actively represent themselves as an ally, somebody who's learning and a partner in trying to see a different system?
Well, one thing, you do get a certificate of completion, but that's only of completing that course. And the designation of ally isn't, we don't give that to ourselves as settlers, that's given to us by Indigenous peoples. And I think Yvette may have some more to add to this. This is a lifelong process. And as Virginia was noting, we will never fully understand what this is like or what this means to us. So being in Indigenous cultural safety is a way of being and a process of learning and being in the work. So, you know, we strive to be an ally, and that designation isn't what this work is about. We won't get a certificate that identifies us as an ally. We'll never get a stamp because we'll never fully be there, because as settlers we live in our white bodies with privilege in this world, and it takes real persistent, consistent examination of what that means in our relationships and in our work with Indigenous peoples. Do you have anything you want to add to that, Yvette?
Yeah, thanks, Laurie. That's a really great question, and what I would encourage people to do is continue to build a relationship with those Indigenous people around you, the communities around you, and look for direction and leadership from the Indigenous people surrounding you to move this forward. It's a very important endeavor that we're undertaking, and having people to walk alongside of us and support that in a really truly collaborative and relational way is important and essential to keeping this going. So thanks for that question.
Thank you very much. I'm just conscious of the time, everyone, so I'm going to wrap us up for today. But before we do that, I wanted to thank Virginia again for joining us, and I'll hand it over to you shortly for our closing prayer. I also wanted to just seize the opportunity to thank again Laurie and Yvette for taking the time to join us today. And I think in hearing your reflections and your learning in terms of where harm occurs, the role of stereotypes in causing harm, the roots of colonialism, the reality that as white settlers will never truly understand that experience, yet also the possibility in all of that and the call for action. And, you know, want to really bring people back to the call for action slide, welcoming everyone to speak up, to truly speak up, talk about racism, name stereotyping, gather data, examine why and where harm occurs, reflect on practice, and reflect on workplace culture. As we move forward, just really quickly, I'm going to highlight the next session. We're going to have Virginia joining us. She'll not only be joining us as the elder supporting our call, she's actually going to be one of our speakers for the next call. So we're thrilled that you'll be able to join us, Virginia. So November 1st is the date, everyone. Mark it in your calendars from 12 until 1 o'clock. Wanted to remind you that as you wrap up today, an evaluation survey will come up on your screen. Please take the time to complete it. We read every one of those evaluations. We really want to hear from you and help inform our next steps. Sue's kindly posted that the session slides and recordings will be shared online, and she shared that link there. So thank you, everyone, so very much for joining us today. We could not move forward with this work without this learning and insight together, and so thank you for joining us. I'll hand it over to you, Virginia, again to close our session today. Thank you.
Stacey, to all of you, I know we all have our own way of relating to our higher power, and we know that many of you may have some special prayers that you'd like to offer. You know, if you have anybody who is sick, to have a prayer for them, for any others who might be suffering in one way or another. And also to remember, you know, that we are grateful for everything that we have, and we show our appreciation to the Creator. Kusai chijal siam, al kustak to mukstam, equal mukmestiu. Creator, we thank you for all things that you give to us. Creator, we thank you for each other, all of the ones who are put together right now for this discussion, and those who are really close to us, our family members, our community members, our elders, our leaders, in whatever capacity they may be leading. We ask the Creator to give them the strength and the courage to keep on moving forward in a really good way. And Creator, help those who are in sorrow right now, and especially a family of mine that they just lost a loved one. And so I know the rest of you will put your heart in your prayer to help the family along, to accept, you know, the reality that a loved one is gone now. And Creator, just thank you for this day and bringing us all together so that we can open up things, you know, that topics that are difficult but are so necessary in order for us to carry on in a much better way in this world. Ocean, all my relations.
Thank you very much, everyone. I want to thank you again, Virginia. We are so honored that you're able to join us and guide us in your wisdom as you had a shared experience. Yvette and Laurie, thank you for joining us. We know you're located in multiple locations across the province and really went out of your way to make this happen today. So thank you for joining us, and we so appreciate your time and you guiding us towards action and change. Thank you, everyone. Have a wonderful day. We hope we will see you all again on November 1st as we continue this journey.
Thank you.
Thank you so much.